welcoming a good friend, Professor Jeroen Bax, past president of the European Society of Cardiology here today. We're going to be talking about imaging to support structural heart disease. And obviously 5 minutes is not enough to cover such a broad topic, but perhaps given the fact that you've really pioneered the field of multimodality imaging, really taught all of us about how to really try to address the patient and the problem with the right test, rather than trying to put the patient necessarily directed to one specific test or one specific modality. So over the last decade, as you see how the field has evolved, any thoughts about multimodality imaging and the challenges and how to best address the clinical questions with the different modalities we have?
Yeah, thanks, John. I think, it really has developed. First, we started only with echocardiography, and we used simple two-dimensional echocardiography to assess what we needed. And then when we worked with that, specifically in transcatheter aortic valve, we started to realize that this echo is not enough, because a lot of the structures are anatomical structures, and these anatomical structures is hard to get the right resolution, and they're not moving much, vessels, etc. So we thought, okay, we need to bring in something like CT. And CT, well, you're the best player in the field, probably in the field of CT. CT is very important because functional, we get from echo, functional information about valve leakages and stenosis, etc. And then the more non-moving things we get from CT. And if you bring those two together, they're very complementary. And then we start to work a little bit more with MRI. MRI is a little bit more complex than the other two tools, techniques, but it gives special information. Probably the one answer that MRI can really bring us is how much leaking volume there is, because that we cannot get done really well with echo, even not if we switch to three-dimensional echocardiography. And we can certainly not get it done with CT, so we need something there. So MRI is probably the best technique for that. So I think we moved away from very simple procedures for very simple thinking, and the things became more complex, and we need checklists with information that we need upfront to decide which patients get what procedure, etc.
I think that's fascinating, and I think we've seen through your work and others that the focus around imaging has always been to support not only the diagnosis, but then maybe to help guide procedural planning. But what we're learning more and more is that some of these advanced imaging tools can help us better understand patient-specific risk, as you mentioned, whether it's myocardial disarray on MR or understanding remodeling of the ventricle strain patterns, which I know you have a lot of interest and publications in. So recently you've published in the tricuspid space, as you mentioned, the aortic valve was our first to tackle with the transcatheter approach, and it was, clear indication and a fairly clear landing zone. Obviously, as we move into the mitral and the tricuspid valve, somewhat more complicated indications and more complicated disease processes. Any thoughts as to how we should spend the next few years trying to understand how to use imaging? Easy question.
Easy question, no easy answer.
But exactly.
To spend the next few years, I think one thing that we learned is that the aortic valve is probably the most simple valve. But the other two, the mitral and the tricuspid, are part of a ventricle more than the aortic. And so in those, the question comes all the time, is it a ventricular disease or is it a valvular disease? And that goes for secondary MR, and that goes for secondary TR. And that's the main burden of mitral and tricuspid disease that we see. Because ventricular disease secondary to coronary disease is what it's all about. So if we talk about mitral regurgitation, that is already complex. I think mitral clipping, we're getting somewhere, we're moving. Transcatheter mitral valve replacement is more complex, as you have published a lot of very good work in that, where we need specifically, again, multimodalities. CT is very important. But now we move to the tricuspid. And the tricuspid is actually, if you look at the cascade of things happening in a patient with coronary disease, so we get 1, 2, 3, 4, 5, 6 infarctions, we treat them all with PCI or eventually CABG. And the ventricle is developing scar tissue. So when the ventricle starts to dysfunction, the left ventricle, your mitral annulus starts to dilate. And then mitral regurgitation comes, LA pressures go up, left atrium starts to dilate because of overload and volume, but also pressure. Atrial fibrillation starts to occur, and then the disease spreads to the right side. And when it spreads to the right side, the right ventricle starts to suffer. And if the right ventricle dilates, it's still repairable, I think, tricuspid regurgitation.
Sure.
But once the RV function goes down, then you can repair probably a lot, but I'm not sure if it's going to alter the future.
Sure.
So these are difficult questions. Ventricular versus valvular diseases, and specifically with the tricuspid, it's going to be very difficult.
Very challenging. That's interesting. Well, maybe in closing, I wanted to focus on another important topic. We're seeing a lot of evidence coming out after the Galileo trial and then the presentation by Raj Makkar at TCT looking at hypoattenuating leaflet thickening, and now we'll have more data coming at the ACC. And so I'm just wanting to glean your thoughts. From my perspective, it seems clear over the last number of years since we first identified this, maybe 5 years ago, that CT without a doubt can identify HALT. And it seems to be slightly more common in transcatheter valves than surgical valves. It seems to not necessarily be tightly linked to downstream clinical outcomes, and in fact it may even resolve sometimes without therapy. But if you were to look at the evidence that we have to date, what do you think are the next studies we need to be looking at, or what sort of investigations would you want to pursue around this complicated imaging biomarker of hypoattenuating leaflet thickening?
Yeah, you say it well, imaging biomarker, that's what it is. I think what we're seeing is that this imaging is outpacing, the technology is outpacing our clinical understanding. That's really what happens in a lot of fields when imaging comes in. So you can visualize everything, but then we don't know what to do with it. We don't know what it means, we don't know what to do with it, and we don't know how to treat it at the end of the day. So we jumped on it thinking, okay, this is a thrombosis, we need to treat it. We see that if we treat that it reverses, but the outcomes are not going to be changed at all. And the bleeding, as we saw in the Galileo trial, is more than the benefit that we get. So the whole discussion is that I think we first need to better understand what it is, and then we can treat it. And if it's clinically relevant, that's the second big question that you have, understanding what it is and if it's clinically relevant. And the data that are out there so far do not point in the direction that the anticoagulation is going to be beneficial, because the good things are outweighed by the bad things, that the bleeding is more affecting the outcome than resolution of the, And also I think probably it can also be that something that resolves in time or stabilizes in time.
We've seen that even in the initial presentation.
So, but the big thing is that with all this advanced imaging, as we spoke about, you got to be careful. You got to think patient central. That comes first. And then try to understand pathophysiology, and then you can link your very nice phenotyping with detailed imaging, can link it to clinics, and then you probably can find ways how to treat it or how to not treat it.
Sure. Well, that's fascinating, and really appreciate your time. There's so many outstanding challenges. We've obviously learned a lot, but I think the coming decade will be a rich one as we continue to move forward with multimodality imaging to support these really interesting and complicated transcatheter valve interventions. Thank you again.
Thank you also.
Thank you.